All this is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. I hope my audio is working. I think it is. So I'm starting with a quick sad news. About half an hour before this lecture, I just heard that my nephew has passed away accidentally, he and his wife. This is the second nephew in my family that has passed away. So um, just pray if you can. And for those who know Dr. Najib, who is my older brother, he's also a medical teacher. This is Dr. Najib's older son. Um, the discussion that I wanted to do today, I had I had a number of studies, and I wanted to do a review of those studies. So let's do that. In the description of this video, there are a number of links to all of these links that are here. I had to remove some of the titles for the links because the 5,000 character limit was exceeded. So some links you have to just open them to see their titles. And secondly, there are some links in the description as well if you would like to support this work. So with this, let's start. This is a study. So I'm going to go over some studies that are interesting. Um, this is a study about rapid initiation of nasal saline irrigation to reduce severity in high-risk COVID plus outpatients. So we've been talking about nasal saline and nasal irrigation. And my last talk, we saw that there were some conclusions from some studies that it is not useful. Some studies said it was useful. So here is another preprint, and this is December 8, 2021. And I wanted to read this conclusion with you. So the results was they had 79 high-risk participants were enrolled. Age was 64 years. Mean age was 64 years. Women, I believe 46%, 71% non-Hispanic white, with mean BMI 30.3. So they were a little bit at risk. Analyzed by intention to treat by day 28, COVID-19 symptoms resulted in one emergency department visit and no hospitalization in 42 irrigating with alkalinization. So it was alkali. They were just that's it. One hospitalization of 37 in povidone iodine group, that is 1.27%, and no deaths. Of nearly 3 million CDC cases, so these are the two groups they had. One where they were just alkalining the nasal passages, and the other one was where they were giving povidone iodine to high risk patients. And then they're comparing them to those patients who were just general patients who were not given any nasal sprays, kind of our standard treatment that here, stay at home, take medicines for fever, etc. So they compare them to those. The total risk of hospitalization of death, 11%, was 8.5 times that of enrolled patients. So what they're saying here is, let me read their conclusion that also articulates it well. SARS-CoV-2 positive participants initiating nasal irrigation were over 8 times less likely to be hospitalized than the national rate. So if somebody was at high risk, and as soon as they started becoming positive, or they found out we have COVID, and they started doing this nasal irrigation or usage of povidone iodine, their likelihood to end up in a hospital or to become severe COVID reduced 8 times compared to the national average, while these patients were high risk patients. So this is a very interesting study. Continuing, this is another study, analysis of COVID-19 incidence and severity among adults vaccinated with 2-dose mRNA COVID-19 or inactivated SARS-CoV-2 vaccine with and without booster in Singapore. And something that is really interesting here, let me see if I can make it bigger. This particular, so among 2 million, 2.4 million individuals, and out of those 52.4% women, 34.7% age 60 years and older. So about 2 million, one half of them almost women, then 34% age 60. There were 319,943 confirmed infections, so 13.1%. Then there were 1,513 severe cases, 0.4% severe cases. mRNA booster effectiveness against confirmed infection, 15 days to 60 days. So check this out, the amount of time we are using to analyze the vaccine, 15 days to 60 days after boosting, was estimated to range from 31.7 to 41.3% for the 4 boosting combinations. However, check this out, 5 months and more after boosting, 5 months and more after boosting, estimated booster effectiveness against confirmed infection waned, ranging from minus 2.8% to 14.6%. And last time somebody had also discussed, when I discussed the UK's study where we saw with after 2 months the vaccine efficacy was negative, and somebody said, how does it become negative? What that means is more incidence or more event on the vaccine side. So here, 5 months and more after boosting, estimated booster effectiveness, this is after boosting, against confirmed infection waned, ranging from minus 2.8% to 14%. Then against severe infection, it stayed. So the green over here is that vaccine or boosted against severe infection, there was good efficacy. And what that efficacy, for example, if you see here, mRNA booster effectiveness, 87.4%, 15 to 60 days, and 87.2%, 5 to 6 months later. Booster effectiveness against severe COVID-19, 15 days to 330 days, about 6 months as well. The 330 is about a year. After 3-dose inactivated COVID-19 vaccine, regardless of combination, was estimated to be about 69.6%. So the study has an interesting outcome. For me, that was interesting is, one, the only benefit, if at all, with the vaccine could be against severe disease. But against infection, there is even negative benefit. And so that is where we stand with the vaccines. Then I wanted to share this about Novavax. So today, this is August 22, today is August 26. Today, CDC Director Rochelle P. Walensky, MD, MPH, signed a decision memo that Novavax COVID-19 vaccine be used as another primary series option for adolescents aged 12 through 17. So that is an additional authorization for Novavax in the US. Although I was looking at Novavax's stocks, and the stock was somewhere about 32, and they said today generally the market was not doing good, and that is why their stock was not doing good as well. But that stock has actually tumbled down in a few months from a higher value. So this is Novavax. Novavax also in the I think we know for the Europe, they have said EU says Novavax COVID shot must carry heart side effects warning. So that is another interesting one. And I think we knew this before. The heart conditions, myocarditis and pericarditis, should be listed as new side effects in the product information for the vaccine Novavax. I do not know why it is doing that. So I'm just going to close this. So this is the Novavax. So in the US, 12 to 17 years are also authorized. Continuing, increasing SARS-CoV-2 cases, hospitalizations, and deaths among the vaccinated elderly population. So this is an interesting situation. Vaccinated population, elderly, have increasing cases and hospitalization. Now, there are a couple of ways to look at it. One way is to say that the vaccinated cohort is larger because more people are vaccinated. And so naturally, when somebody, let's say on one side, there are a million people who are vaccinated versus there are 100 people who are not vaccinated, then the absolute numbers will be different. However, percentages could still hold until the sample size on the unvaccinated side becomes too small. But this is an interesting data point. July 11, 2022. This is UK. So if you read here, let me actually read the conclusion first and then we can look at the data. There is no discernible optimal vaccine effectiveness among 18 and above years of age, vaccinated third dose population since December 2021 during the beginning of the Omicron variant surge. So, no benefit of the vaccine against Omicron. Pre-existing conditions, ethnicity, deprivation score, and vaccination rate disparities data need to be adjusted by the development of validated models. The increased proportion of cases with significantly increased risk of hospitalization and deaths among the elderly population during the Omicron variant surge underscores the need to prevent infection in the elderly, irrespective of the vaccination status, with uniform screening protocols and protective measures. And we know that there are other algos as well. The important thing here, I have this PDF open here as well, and I went over the PDF too. The interesting thing here is, look at this. Total cases, 22 million. Hospitalizations, about 848,000. Deaths, 175,000. This is UK. 22 million cases, 848,000 hospitalizations, 175,070 deaths. 51.3% of the cases, 51.3% of the cases, which is about 11 million something, and 28.8% of hospitalizations and 16.4% of deaths occurred during the Omicron variant stages. So cases were higher, but the hospitalizations and the deaths were actually lesser than previous variants. When comparing the period of February 28, May 1, 2022, so February 28 to May 1, 2022, with the prior 12 weeks, we observed a significant increase in the case fatality rate. So this is rate, not absolute number, 0.19% versus 0.41%. So before Omicron, 0.19%. After this, 0.41%, and the risk reduction is twofold, 2.1. And the risk of hospitalization, similarly higher. During the same period, we also observed a significant increase in the proportion of cases among 50 years of age and hospitalization and deaths among 75 years of age. The vaccine effectiveness for the third dose was in negative since December 2021, with a significantly increased proportion of SARS-CoV-2 case hospitalizations and death among vaccinated, and a decreased proportion of cases, hospitalization, and deaths among unvaccinated. So once again, you could look at it to say unvaccinated cohort size is smaller, so relative proportion would be smaller as well. But still, this is this is a preprint study, because folks would like to point out that this is a preprint and like to dismiss it. I think we should not dismiss the data. We should look at that data and try to understand what is going on, and then see how to fix these things, instead of having a war for, is it a news which is good for vaccinated versus unvaccinated, or is this a disinformation? This is a study, and this study includes 22 million people's data from UK. So it is an appropriate, correctly done study. It's just that what it is showing is, in elderly patients who are even vaccinated, the risk of hospitalization and death is increasing. That means what we have to see is the vaccine efficacy against Omicron after longer period of time reducing? And I think we all are aware of it, that it is reducing. So that is how to look at it, and to see what else can we do to protect elderly or protect all of us. And a few days ago, I read a study. I actually mentioned that here as well. Dr. Ali, who had done that Veterans Affairs Hospital study, I think he works in the Veterans Affairs Hospital. He had said in one of his interviews that it is time for the US to have a national debate or a discussion to figure out what else needs to be done than just the vaccines. So I think it is slowly becoming mainstream discussion to say we need to look beyond the vaccines, because vaccines are not fulfilling their promise as was communicated. So this was an interesting study. The links are in the description. Here is the Novavax. I just went over this. So Novavax is once again the only issue to see with Novavax is the myocarditis. So I will actually pull some more data together here in this. I believe this is John Hopkins. So in this John Hopkins article, they talk about the clinical trial with the Novavax, and 40,000 people were in there, and there were 6 cases of myocarditis. Although I have become less comfortable with the clinical trial data results, considering um, vaccines like BioNTech that had said no myocarditis, and then there is huge amount of myocarditis. The Thailand study, so many people would like to dismiss that, to say this 29% includes heart rate change or the EKG change, which are temporary, which can happen to anyone. So that's dismissible. But as I had discussed it, in the Thailand study as well, there were 2.3% of the cardiac biomarker and pericardial effusion patients. That is a very high number. So here, 6 patients out of 40,000. But once again, I think we need to continue to collect more data. Now, this is another one that I thought was interesting. This is the um, you know that there are a number of folks who, and you would see under these videos, under my videos, sometimes people come in and write that this virus has never been isolated, or they ask me that what are you talking about while this thing is not isolated. Some of the folks write stories there that a doctor tried to isolate, she could not, and then she asked 6 more people to isolate the virus and they could not, and so on. So, and I have been sharing, it's kind of a eye candy for a medical doctor to be able to see these viruses. When I started medicine with myself and Dr. Najib, whose son unfortunately passed today, Najib was 4 years older to me. We were both in the same college, King Edward Medical College. In those days, we were not able to see viruses. So for us to be able to see viruses is a great opportunity. So here are some viruses, and I had opened up this bigger pictures of these. So let's go over some of these. So these blue ones are viruses, and they're coming out of the cultured cells. And this virus was actually taken from a patient in the US, meaning they took the swab and the virus was there, and then they cultured it, and here is the virus. Then here, this is also, these golden guys are the SARS-CoV-2, and these other are the tissue. And as you can see, the SARS-CoV-2 has this little, excuse me, corona around this. These are the spikes, these little bubbles around the virus itself. These are spikes. Then here as well. So this is virus actually emerging from the cell surface. Imagine that this huge white surface is actually the cell membrane. And some viruses are still within the cell, and they're still slowly popping up, like boiling from the surface upwards. So if you see here, this little gray one is still just pushing from inside to pop out. But these bigger ones have already emerged a lot from the cell. So these are actually kind of emerging from the cell surface. What a beautiful picture. This is another view of the same one, another view of the same. Then I don't think we needed to see this green sample, but here is another actual picture of this virus, SARS-CoV-2, with these spikes around it. These spikes are all the evil that we have nowadays. And here again, the virus is emerging from the tissue. This is also virus. These little structures that you can see are actually the cellular vesicles, the structures within the cell, and they are sliced, and you can see the little, I almost suspect that this little folded structure is mitochondria, but these are various structures here, and the virus is present here as well. So I thought I'll go over these. These are very interesting. Look at this. Can you imagine this? These are actually budding viruses from the cells. Okay, so that is the viruses. Then this I saw on Discord. I believe John or Texas or somebody had left it, and this is a new way of looking at the or tracking the virus data as well. So if you are interested, you are nerd for excuse me, virus mutations, then you can follow that over here. Then here is one more preprint. Inconsistent direction of change in case severity across successive SARS-CoV-2 variants. So generally what we feel or what we are seeing in the data is that severity is reducing with Omicron. However, here in this preprint, they are saying that we are not sure exactly if it is reducing or not reducing. I still see that after adjustment, if you see here the green one, after adjustment, the median cumulative odds ratio was 0.49 for Omicron versus Delta. So 0.49 is almost half the severity. But they still conclude and they say the direction of change in disease severity between successfully emerging SARS-CoV-2 variants of concern was inconsistent. This heterogeneity demonstrates the severity associated with future SARS-CoV-2 variant is unpredictable. Interesting. And so they've given various changes in severity. For example, over here, alpha to delta, then delta within the delta, and then delta to Omicron. Although I saw that delta to Omicron, the severity is actually reduced. Then this is another interesting study, association of COVID-19 infection with wearing glasses in high prevalence in Denmark and Sweden. And so that was interesting. They said that we did this study because there was another study from China that said a study from China formed the basis for the hypothesis that wearing spectacles could protect against COVID-19 infection. And we have actually discussed this in the past as well. Plus, there are actually in the microbiology books, it is written for SARS-CoV-1 and MERS-CoV that to protect yourself, wear a mask and glasses and so on. This study says we have found no benefit of wearing glasses or spectacles. So here, conclusion and relevance. While wearing one's glasses was inversely associated with COVID-19 in Sweden in an unadjusted analysis, an association no longer was identified. When adjusting for confounders, the results provide inconclusive findings regarding whether wearing one's own glasses is associated with a decreased risk of infection. That's an interesting study for me to see that just like there are studies from masks, this is a study that says the glasses are not useful. That's interesting. Now here, this is, I think, so I believe that not everyone here is a fan of masks, but I have been using masks for 2 years. There are some who actually are fans of masks as well. For me, what is interesting is what they did was these researchers, they said if you just have this little, surgical mask, which is not N95, but if you can bind it to your face, kind of seal it with these rubber bands, and they've given this the way to seal it, then they said it becomes as good in its performance as N95. So check this out. This is very interesting. Rubber bands, a low cost and easily accessible modification can improve the seal and protective ability of a standard surgical mask to the level of an N95 respirator. This could mitigate N95 respirator shortages worldwide and provide individuals in under resourced regions a practical means for increased personal respiratory protection. So that's a very interesting idea. So I thought I'll share this as well, even um, with the caution that I would think that some of the audience will become upset that why am I talking about the masks. But this was a very genius idea and simple as well. Then here is another study. It is in the Journal of Pediatrics. The COVID-19 pandemic is associated with a substantial rise in frequency and severity of presentation of youth onset of type 2 diabetes. We did this discussion as well. And that discussion was I think about 2 years ago. I presented a study about SARS-CoV-1 that young patients who were infected with SARS-CoV-1, 10 years later, their propensity to develop diabetes compared to their healthy age mates was more. And the thought was in that study that SARS-CoV-1 had caused pancreatitis or had caused other metabolic organs or tissues infection and damage, which then resulted in earlier diabetes because parts of pancreas were destroyed during the infection. So here is a study that is saying that the youngsters during the COVID-19 had more diabetes that they were reporting. So a total of 3,113 youth. Mean age was 14.4 years, 50.5% female, 40.4% Hispanic, 32.7% blacks, 14.5% non-Hispanic whites were assessed. New cases of type 2 diabetes increased by 77.2% in the year during the pandemic, N equals 1,463, compared with the mean of the previous 2 years, 2019, 886, and 2018, 765. So almost doubled, or 77.2% increase. And so then they say the burden of newly diagnosed youth onset type 2 diabetes increased significantly during the COVID-19 pandemic, resulting in enormous strain on pediatric diabetes healthcare providers, patients, and families. Whether the increase was caused by COVID-19 infection or just associated with the environmental changes and stressors during the pandemic is unclear. So they're not saying it is infection, they're just saying we saw more diabetes. And it is very true that stressors are possible. There is a thing called stress diabetes because when we are under stress, we release the stress hormones whose job is to try to increase the glucose level in our body to make more glucose available to muscles and brain to function and run. And for in that process, these hormones can block the entry of glucose into the cells or provide resistance to insulin, so that if persists can cause diabetes like situation. Many times when the stress goes away, this condition reverses, but if there is damage to pancreas, then it is possible to not reverse. This is why I keep saying we all have to take care of our stresses. Our hearts can become irreparably damaged when they become remodeled with continuous palpitations and continuous stress on them. Similarly, our pancreas can become damaged if there is continuous opposition to pancreatic function, and we keep just pancreas keeps trying to get the glucose in the cell. The cells are not able to get the glucose because of the stress hormones, and pancreas keeps pumping out more insulin. That puts more pressure on the pancreas, more pancreatic cells die, and that can become irreparable as well. So stress is very important to keep in check. And that is my request to everyone here. Nowadays, stresses are even more. And not only this, that we have a stress of a pandemic, then we are divided, we are fighting with each other, we are quarreling, our finances are in trouble, our psychological health is in trouble, social aspects are in trouble. It's just a mess at this time. So whatever you can do to move yourself in a more happy direction, that will be very, very good, and has long term benefit for you. Here is another study: persistence, prevalence, and polymorphism of sequelae after COVID 19 in unvaccinated young adults of the Swiss Armed Forces, a longitudinal cohort study. So, here what they did was, so these, everyone who participated were unvaccinated. Young, previously healthy individuals largely recover from SARS-CoV-2 infection. However, the constellation of higher BMI, dyslipidemia, and lower physical endurance 180 days after COVID 19 is suggestive of a higher risk of developing metabolic disorders and possible cardiovascular complications. And this actually kind of tells you that how we are stuck in this, um, what is that, the hard and the rock and the hard place, that vaccines are not being effective, vaccine side effects are also quite scary, and here the infection itself can also cause irreparable damage to some. The only fortunate thing at this time is the the severity is reducing, and the excuse me, percentage of severe cases are reducing. I presented that Qatar study in which the patients who were becoming, again, that was relatively youngsters in Qatar, but we also have youngsters in America. So that could be a one on one. And they saw that the uh, severity was in small percentage, even below 1%. This used to be 19% when the pandemic had started. Now, this is another study, a pilot of a randomized controlled trial of melatonin and vitamin C for mild to moderate COVID 19. Guess what? Of course, I'm a fan of vitamin C. And there are so many doctors who are fan of vitamin C, and vitamin C is a big um, support during stress times on our tissues or infections. This study says that vitamin C made no difference for COVID disease or progression or symptoms, but melatonin made statistically significant difference. So that was interesting for me. Again, inside my heart, I don't really agree, because I believe vitamin C is a very good um, choice during these infections. And there are so many studies that show how it is useful. Here is a study that compares it to melatonin and says melatonin is more useful. So it is interesting from that point of view. So look at this: 98 out of 104 recruited, mean age 52 years patients completed the study. Regarding symptom progression, those patients taking placebo and vitamin C progressed at the same rate, so no difference. When compared with those taking placebo, the group taking melatonin had a faster resolution of symptoms, and coefficient is 0.63, and the values are correct as well. By day 14, all three groups had reached plateau. So at the end of the day, vitamin C or melatonin or placebo, they all reached a plateau of the infection and symptoms, but melatonin had accelerated it better than vitamin C. Again, at least in this study. Quality of life impact analysis demonstrated that the group taking vitamin C improved at the same rate as the group taking placebo. So, once again, no difference. The group taking melatonin had a faster improvement in quality of life. By day 14, all three groups reached together. So then they say, conclusion: vitamin C 1000 milligram once daily has no effect on disease progression. Melatonin 10 milligram daily, this is very high. I cannot even take 1 milligram without having nightmares. Melatonin 10 milligram daily may have a statistically significant effect, but it is unclear if this represents a clinically significant benefit. So they said statistically it is It helps, but does that clinically help it at all or not? Because all three groups, including placebo, by 14 days had become recovered equally well. So further study is warranted. So this was very interesting for me to see a study saying vitamin C doesn't work, but melatonin works. Now, here is a study that is the most controversial in our discussion today. And I can actually understand why it is controversial. You may have seen this as well. Duration of, actually, I'm sure you have seen this, duration of shedding of culturable virus in SARS-CoV-2 Omicron BA1 infection. This is a letter. It is a letter to the editor. Interesting thing is this. Let me back up for a second. From the face of it, this letter, this little graph tends to show that those who are vaccinated, they clear the virus later than those who are not vaccinated. And let me show you that graph here. So if you look at this graph, they had done two parts of the study. One was PCR conversion, and that is you take the nasopharyngeal swab and you do PCR test on it, and you see how long the PCR stays positive. The second part that they had done was that from the same swab, they took the virus and tried to culture it. And they wanted to see how long from the nose of a person culturable virus can be taken, because that will be the indication of shedding as well, because there is a viable virus that is being shed. And interestingly, they did study by, or this little thing, the letter they wrote was a study for them where they compared Delta and Omicron, and they compared vaccinated and unvaccinated. And I think when you will look at this data with me, you will agree that the message that became that vaccinated clear the infection slower, that actually shows here. However, as soon as that message started taking root, then the authors, they once again, so I have this routers over here and some others, they reached out and they talked and they said, well, this is not the correct conclusion. And we actually showed that vaccinated were able to become culture negative one day earlier than unvaccinated. And it was very interesting for me that if the authors had not said that information, then the data that they shared does not show that information. So it is kind of an interesting thing that the study or whatever letter they wrote, that didn't show that there was that didn't show what they were saying afterwards. But then they were now writing letters and they were writing emails and they're doing. So I think that this was a hastily written letter. I think that the authors knew what this letter is going to do. It's just that when they got that pressure, they then started clarifying. Secondly, and I would go over these graphs with you, these charts with you. Secondly, for me, what is interesting is there still is. So, for example, Trial Site News said there is a bombshell that we have these issues. I think the more interesting problem here to see is the following. That is, vaccine was supposed to help. I had always been saying that vaccine generated antibodies and the memory cells will become active as soon as somebody becomes infected. Within 10-20 hours, the body would start clearing the virus, and the virus will be gone faster than it will go away in an unvaccinated person. It is actually understandable that with the Omicron that escapes vaccine, that the patient will not be able to clear it fast enough. However, that should be something to look at to say, well, have we reached a point where we are comparing vaccinated to unvaccinated with a day And we are fussing about that and not looking at the bigger picture to say, why at all was a vaccinated person continued to be infected for this many days? Is this a natural outcome? And it is possible. We can't make a vaccine for coronaviruses. Or is this these vaccines design? Or is this the cohort with the vaccine was, let's say, older or had more comorbidities and so on? Meaning, instead of actually looking at that even if these were same equal number of days, vaccine, I am vaccinated and infected as well. Vaccinated individuals should have that arsenal of of the immune cells and memory cells to quickly ramp up an attack. You could argue that unvaccinated are more youngsters, better immune system, they take care of themselves better, they've been doing various protocols that others may not have been doing, and so on. That is where the discussion should go, instead of fighting over a day or two. For me, the question was, why at all did this happen? Shouldn't this have been 3 days for vaccinated and 5 days for unvaccinated, something like that, instead of saying, is it 1 day more or is it 1 day less? So with this, let's look at the graph that they wrote with the letter, and then their messaging afterwards that they sent to various fact checkers. So here, I'm going to go here. Imagine we are looking at it for the first time. We have no fact checking information. The authors have not provided anything more. This is what we have. It is published here, July 21. And in here, if I open up this little diagram that they have, look in this diagram. And once again, I am sure that you have all seen this, and I'm just catching up with you. In this diagram, let's start with the diagram B. B is time to PCR conversion. So start of the symptoms to becoming PCR converted, and then to go away from PCR. Now, PCR, they're correct, the authors, to write emails afterwards to say PCR positive does not mean viable virus. It can be broken RNA sitting in the cells, which is fair. And they said, this is what we were trying to figure out, that how long the PCR stays positive, the virus debris stays in the nose, compared to culturable virus that we can get, which would tell actual viable virus shedding. So these are the two graphs here. The B graph over here, for example, let me see if I can make it bigger. I do not know if I can. Yes. So B graph here, this one, days since first positive PCR assay, that is the timeline, 5 days, 10, 15, 20. And the y-axis is percentage of participants with positive PCR. So first, there has been all these fact checkers, or let me back up. I feel that the messaging in the trial site news was not exactly what this is showing, but that is their issue. They have to figure it out. But there was a huge pushback to say they did percentages. They should not do percentages. Well, here in this y-axis, percentage of participants with positive PCR. Then they use the percentage. Then the next thing that you could say is, what are these little brown shaded areas or purple or blue? So these are 95% confidence intervals. So these are Kaplan-Meier charts. So if I go in here, for example, let's say this is B, and I'm just going to take any one of these here. For example, the red one is Omicron. The way to look at this one is to say, okay, at day 15, if I go here and I then connect it to the y-axis, to me it seems like about 25, 26, 27, 30%. I'll read it this way, right? Percentage of participants with positive PCR about 30% Omicron variant at day 15. And then this bar, the area, is actually 95% confidence interval. And if you see, I think it does not cross the unity. And so it is a statistically significant data point, and its upper range is here and the lower range is here. So 2 points here. One, they are talking about percentages. So when somebody looks at the percentage and says, well, the percentage looks really strange for the vaccinated being more percentage than non-vaccinated, then we cannot start pushing back and saying, why are you talking percentage? The data is too small. If the data is too small, which is correct, the data is actually too small. It is what, 60, there was some data here, 66 patients. If we take that data is small, then what I have seen with the other studies that have small number of patients, they actually put the whole patient's chart, anonymized chart, the whole chart out there to say this patient, male, 45 years of age, became positive here, 5 days, 10 days. They can actually, for these small number of patients, provide that data instead of writing emails afterwards to say, oh no, you actually do not know, but we looked at the data and it was median time for culture conversion was 5 days in vaccinated versus 6 days in unvaccinated. Well, we cannot just figure out that data by ourselves. To me, it seems really surprising that on one end, the data written here shows the and leads towards the interpretation that happened. And then there is this pushback to say you are interpreting wrong. So this is the B. Now let's go to D. It is interesting as well. Time to PCR conversion. Now, PCR conversion, once again, presence of PCR positivity does not mean infectivity. And these researchers did something very interesting. They said a person may be PCR positive for 10 days, but they're only viable infected particle positive for, or culture positive, as they said, for 5 days. So for the remaining 5 days, they just have the debris in various cells lurking around. Good. That's a very good thing to understand. But if you look at the data, it does raise this question to say, why is vaccinated data almost similar, or actually apparently, let's look at it together. So I am not making up these statements. D, time to PCR conversion. Again, PCR conversion means live virus or broken virus, doesn't matter. We do not know. So here, unvaccinated is the solid red line. Vaccinated is dotted line. Boosted is green. So if you see here at the bottom, number at risk, how many people were at risk at various time frames. So at the 0 day, there were 16 unvaccinated, 37 vaccinated, and 13 boosted. And this y-axis here is the percentage. So if you see percentage of participants with positive PCR, it is a percentage already. And the area is the 95% interval. So if you see here at, let's say, 10 days or 15 days, the boosted green one and the unvaccinated solid red, you can see that the solid red is actually lower and the green one is actually higher. And they could have said, look, the people who were vaccinated, that group was, let's say, had more comorbidities, or that had this. We don't have that data. In the absence of all of that data, the graphs, we cannot fault someone to interpret it this way to say, well, on day 10, more vaccinated individuals were still PCR positive, or day 15. And similarly, what is more interesting for me, regardless of this little fight that is going on or quarrel, what is interesting for me is this side, the C and E. This is actually informative for me as a doctor. What is the C saying? C is saying time to culture conversion. So if you have this question in your mind, that when will a person actually become culture negative, will not be shedding anymore, then they're saying that if somebody has Omicron, then if you see by 15th day, they're for sure not shedding. And Delta, by 15th day, they are for sure not shedding. However, if you go here, look at the percentage of participants with positive culture on 10th day, the red is Omicron and the blue is Delta. Delta was already taken care of while Omicron was still present. This is now culture conversion, that is infective viable virus, that is culturable virus. That is a very interesting thing to know, and that is what their graph is showing. Similarly, down here, this is the graph that is all the fight about. Time to culture conversion in vaccinated, unvaccinated, boosted. And if you see here once more, let's look at 10th day. So first look at the 15th day. By 15th day, somebody was vaccinated or unvaccinated or boosted. They were all clear. At least in this study, small number of participants, 66. So by 15th day, done. Nobody is shedding anymore. Now at 10th day, there are unvaccinated who are shedding, there are vaccinated who are shedding, and there are boosted who are shedding. Now, if you look at their percentages, let's not do one of the pushback in fact checking was that they converted it in percentage. Fine, let's not convert it in percentage. Let's just read the percentage map they have given. Let's not do double percentages on it. So on 10th day, boosted is the green line. So if I go here on the 10th day with the booster, and if I extrapolate that or connect it back to, not extrapolate, connect it back to the y-axis, it is about 30, I would believe. So 30%. And then there is a range of this area that is the upper and lower limit for the 95% confidence interval range. That's a large range. If you now look at unvaccinated, that is this solid line, then on 10th day, that line is actually lower. It is 10% or so. And if you see here, there is not much of a area there as well. To which their answer was, this data is too small to make such conclusions. But man, that is the graph here. And they actually have another supplemental graph as well that is also similarly interesting. So I thought it was interesting to look at this as well. So that is the discussion for today. Please like, subscribe, and share. There are some links in the description if you would like to support their work, this work, my work. There are links. You can become part of Drbeen, or you can use PayPal, or you can buy me a coffee, or you can become part of YouTube or Patreon, and so on. So with this, please have a good weekend. Stay safe, happy, and healthy. I would see you on Monday. Bye for now.